Hi, I'm Dr. Richard Isaacson, and today I want to talk about a practical clinical perspective on an incredibly important and nuanced topic: blood biomarkers for Alzheimer's disease and related neurodegenerative diseases. Let's start with a saying that might sound familiar: trust, but verify. President Ronald Reagan used it during nuclear arms negotiations with the Soviet Union. But honestly, it applies just as well to how we should be thinking about early blood biomarkers for Alzheimer's. Over the last 5 years, research in this space has exploded. We've seen headlines claiming the new Alzheimer's blood test is here, calling it revolutionary and game changing. And yet, in real world clinics, especially with pre symptomatic individuals, these tests are still barely being used. So, what gives? In my clinical experience, after seeing over 1,000 patients at risk for neurodegenerative disease since founding the first Alzheimer's prevention clinic in the United States back in 2013, and having used more than 150 different blood biomarkers across hundreds of people in both research and clinical practice since 2020, I've come to one conclusion: we need to proceed with caution. Now, let's break this down. First, who should use these markers? And just as importantly, how should they be used? Some markers like p-tau 217, p-tau 181, and p-tau 231 don't behave the same over time. They rise at different points on the disease spectrum. If you're trying to figure out where someone is on that journey, you have to know which marker to pick and when. Is just one marker enough? Often no. Do we need ratios like p-tau to amyloid beta 42? Probably. What about a full panel? Quite possibly even more. The truth is, the more we look, the more we realize how complex this biology really is. And it gets deeper. Men versus women. Does sex matter when interpreting results? What about age, body weight, other health conditions? Is someone carrying an ApoE4 gene variant? Does that matter? Even things like recent illness, viral illnesses especially, sleep deprivation, or whether the person exercised that morning can cloud the results. Then there's sample handling. Was the blood shipped frozen, on dry ice? Did it sit in a lab over the weekend? These small things can drastically change the outcome. Let's say a sample is run one time. Are we sure that's enough? Some of these tests show significant variability, even when running the exact same sample more than once. That's why we often recommend running samples twice or more in duplicates and watching those coefficients of variation carefully. And what about all those flashy new studies in the news? Here's the question I always ask: is the test in that study the same assay or same test as the one being sold commercially today? Is it the same reagents, the same calibrators? Because if it's even slightly different, those results from that headline-grabbing study may not apply much at all. In our ongoing research at the Institute for Neurodegenerative Diseases, we've now followed more than 200 people with risk factors, those with symptoms, and even healthy controls. Every participant receives longitudinal blood biomarker testing over time, often with dozens and dozens of markers across multiple technologies and multiple platforms. Many receive interventions to try to reduce their risk, and this allows us to measure how their biology changes in response. Our research has been presented so many times at the American Academy of Neurology meeting, the Alzheimer's Association International Conference, and the Society for Neuroscience, most recently all in 2025. This shows that with multimodal personalized care, our research has demonstrated that we can actually shift biological markers of disease in a meaningful way, and that's exciting. But most existing studies only focus on blood biomarkers for early diagnosis in those people that are symptomatic, not for monitoring risk, tracking progression, or measuring response to preventive interventions in an asymptomatic person. That's where our work diverges. Unfortunately, this gap between research and real-world use can put patients at risk. If we misinterpret the results or apply the wrong context, we can make diagnostic or treatment decisions that are just plain wrong. And let's be honest, right now the field is flooded with new blood tests, biotech players, and marketing campaigns. But there's very little transparency. It's still unclear which tests are accurate in real-world settings and which ones truly track a person's response to therapy. At the Institute for Neurodegenerative Diseases, our mission is to change that. We've drafted a position statement on blood biomarkers anchored by 4 principles we call the 4 A's: accessibility, accuracy, actionability, and affordability. We believe brain health education and access to testing isn't just good medicine. It's a moral imperative. Everyone deserves to know where they stand and what they can do about it. We've also created a code of conduct to promote transparency and maintain integrity in this rapidly changing space. Because the truth is, innovation is happening weekly, but confusion is growing just as fast. Patients and clinicians alike need a compass. So now let's talk about specifics. Who should be tested? Should it be symptomatic people only? Or is it time to empower asymptomatic, at-risk individuals who want to know their biology early? How should testing be done? Should your primary care doctor order it? Or does it require a subspecialist? What labs and platforms should be used? Should results be confirmed? And how are those results explained? By doctors, counselors, educational tools, or just a one-page handout as you leave the doctor's office? And what tests are we actually talking about? Just p-tau 217? What about the different forms of p-tau, like 181 and 231, higher weight or lower molecular weight, which represent different biological origins? And what about other markers like GFAP or NFL, brain inflammatory markers, amyloid beta ratios? The list goes on and on. Some markers are more useful in symptomatic people. Others might be better for tracking risk over time in an asymptomatic population. And using a single marker in isolation, especially without much context, may lead to false positives. We've seen it ourselves. For example, in our cohort, we've had patients with elevated p-tau 217 levels who were later found to have active herpes simplex virus infections, suggesting that the elevation may not truly reflect active, ongoing Alzheimer's pathology at all. In other cases, people with the same infections had a normal p-tau 217. That alone should give us pause. The reality is, Alzheimer's isn't exactly just one disease. It likely has multiple flavors, and we need to identify the combinations of biomarkers that define those subtypes. When it comes to ApoE genetics, even that gets tricky. Having one copy of ApoE4 genetic variant doesn't always mean higher levels of that protein expression. We've seen people with one or more copies with higher biological impact. What does this all mean for disease risk or treatment response? We have many, many, many questions now, and many more questions than answers. But the good news is we are getting closer every day. So at the end of each day, I believe that right now, no single marker is enough. The dream of a one-size-fits-all Alzheimer's test, I don't think we're there yet. And until we are, we owe it to our patients to move carefully, to tread lightly, to ask the hard questions, and to never overpromise. Because with Alzheimer's disease, getting it right and doing it early matters more than ever. Thanks for watching, and thanks for being part of this important, ongoing conversation.